How should we dose vancomycin and monitor its pharmacological parameters? We are going to reflect on the recently published vancomycin use guidelines. And welcome to Editors in Conversations. This episode is brought to you by Antimicrobial Agents and Chemotherapy Journal, available at aac.asm.org. I am your host, AAC Editor-in-Chief Cesar Arias, and this podcast is supported by the American Society for Microbiology, which publishes AAC. In the August issue of AAC, you may find very interesting things, including our recent podcast with the chairs of the NIH and IDSA guideline for COVID-19, and very cutting-edge research, for example, in mechanisms of resistance to metronidazole in Clostridioides difficile, a new variant of KPC resistant to ceftazidime-avibactam, and a description of the activity of ultra-broad spectrum beta-lactamase inhibitors, among many other cutting-edge research. You can find this issue at aac.asm.org. Joining me today to discuss the new vancomycin guidelines, I have two really exceptional, distinguished guests. Dr. Michael Rybak is actually the chair of the Vancomycin Guidelines group. He's professor of pharmacy and medicine and director of the Anti-Infective Research Laboratory in the Department of Pharmacy Practice, Eugene Applebaum College of Pharmacy and Health Sciences, Wayne State University, Detroit, Michigan. And Dr. Catherine Liu, who is the chair of the IDSA Guidelines on Staphylococus aureus bacteremia. She's an associate professor in the Vaccine and Infectious Disease Division, Fred Hutchinson Cancer Center, University of Washington, Seattle. Welcome to the Editors in Conversation.
Thank you.
So let's start with Mike. There has been a lot of anxiety about this vancomycin guidelines. A lot of people expecting to be published, and they are here. I just want you to give us a background of, since you have been involved heavily in both guidelines, what the old guidelines were and what was the rationale to develop new guidelines in the vancomycin use.
Well, Cesar, as you know, it's been about 10 years since the first guidelines came out in 2009. And there's been a lot of data that has surfaced since those guidelines were first published. And so the impetus to go back and look at this was basically to review the last 10 years of data since those guidelines are out and to see basically how we've done with the original guidelines. And I guess the primary difference, if we want to relate the differences between the guidelines, the primary difference that with the new guidelines is that we are no longer recommending trough monitoring. In fact, we are recommending the area underneath the curve as the primary method for monitoring vancomycin. And this was done primarily on the basis of safety. If you go back and look at the last 10 years, our initial recommendations were to monitor troughs of 15 to 20. And that was based on a surrogate marker. The pharmacodynamic parameter that predicts vancomycin efficacy and toxicity is the area underneath the curve, divided by the MIC. And since we tried to make it easy back then in 2009 and have people monitor trough levels only and use this as a surrogate market for our true target, which is really the AUC of 400, we thought that was the best way forward, the most simplest approach. The last 10 years has really shown us that that approach has actually increased the rate of nephrotoxicity significantly from prior use of the drug, prior dosing guidelines. So that was the primary reason for going back and reevaluating those guidelines to see whether or not we could make changes that would improve the safety and hopefully possibly also improve the outcome as well for our patient population. One of the biggest differences as well, besides the AUC and no longer recommending troughs, is the fact that we included pediatric patients this time, as well as special patient populations like patients who are obese. And I think that's helped a lot because those are standout questions that we had for some time now. Just what do you do in the pediatric population? And what do you do with an obese patient, especially since we dose this drug on a milligram per kilogram basis on total body weight? So I think those are probably the major differences.
Thank you very much. That's a very, very strong rationale. And Dr. Liu, you've been involved in this guidelines process as well as you are working, I know, very hard in the Staph aureus bacteremia guidelines. As an infectious disease clinician, what are the rationale that you think was important for revising these guidelines, and particularly how to use this drug that as a first-line therapy, as many people are using against Staph aureus?
So thanks again very much, Cesar, for having me on this podcast. And I think as Mike has already alluded to, one of the major drivers that I think really prompted the revision of these guidelines was the new data regarding the safety of vancomycin. So this has really become, I think, a patient safety issue. I think in particular, following the 2009 guidelines, there have been a number of studies that have been published that have raised concerns over, as Mike has already mentioned, vancomycin-associated nephrotoxicities, as we saw clinicians responding to those guidelines by increasing doses in order to achieve the therapeutic target trough concentrations of 15 to 20 as outlined in those prior guidelines. And when those previous guidelines were published, that trough target was really thought to be a practical and a reasonable surrogate for the optimal vancomycin AUC over MIC, but acknowledge that there were limited safety and efficacy data at that time. And since then, I think there's really been accumulating evidence to suggest that these trough concentrations are not optimal surrogates for AUC values. And I think what we've seen in the literature is that a range of AUCs can be achieved by different dosing regimens, may actually yield the same trough values. And so the other issue is, I think, surrounding the issue around clinical efficacy. There has been no data that has supported that maintaining these higher trough target concentrations of 15 to 20 has been associated with improved clinical outcomes among our patients. This coupled with a number of studies that have shown that higher troughs greater than 15 were associated with an increased odds of nephrotoxicity, as well as additional studies, including the prospective multi-center PROVIDE study showing that higher vancomycin AUCs were associated with an increase in probability of AKI compared to lower AUCs. I think all of these findings have very significant clinical implications from a patient safety standpoint, including increased patient morbidity, prolonged hospitalization, as well as healthcare costs. And so I think for the practicing clinicians, just thinking about, as people start thinking about shifting towards this new strategy, is that AUC guided dosing allows for a more individualized, I think, approach to managing patients, that we can perhaps achieve therapeutic exposure at lower doses with lower toxicity for our patients.
That's a very important points. Before we go a little bit deeper into this logistics of understanding what is in the guidelines, I want to touch base about the MIC issue, particularly because it's incorporated in these pharmacodynamic parameters that drives some recommendations. And the inconsistency, as you can call it, with this determination based on different techniques and specificities that people have in different approaches. So for Mike, and then I would like to hear Catherine also opinion on this. How do you address this issue of MIC when you are thinking about calculation of AUCs and dosing in vancomycin?
So Cesar, that's a great question. And the committee actually spent a fair amount of time on this question regarding the MIC. And actually, Catherine led up that section with Don Levine as well, and she'll have her own comments on it, I'm sure. But the MIC is a problem for vancomycin. It's a very narrow range, somewhere between 0.25 and 2 for the most part. One of the problems with determining the MIC for vancomycin is, how do you determine what is the system that gives us that value? Our clinical microbiology department is responsible for doing susceptibility testing, and our clinical scenario where we're asking for this to be done so we can better care for our patients, but what are they actually doing with it? And most large hospitals, including our own at Detroit Medical Center, are using automated systems. So they're using Microscan, Bitech2, Phoenix. There's a variety of systems that are out there. And unfortunately, depending upon which system you're using, you can get differences in results. In other words, if I have done the gold standard MICs by microbroth dilution and determined that to be a 1, for example, I could send that to someone doing Phoenix. They can tell me it's a 0.5 because Phoenix tends to undercall these values. Send it to another colleague that uses Microscan in their system. They might tell me it's 2. It tends to overcall based on their algorithm for their automated system, or somewhere in between if you have Vitec 2. So the span of answers you'll get back for that MIC varies depending upon the system. And then if you throw on top of that, people who use e-test methodologies, as well as Catherine, is that the inoculum effect is present there for vancomycin compared to the microbroth dilution methods for MIC testing for vanco. The e-test uses a 20-fold higher inoculum on an agar plate. And therefore, we have an elevated in MIC somewhere between a half step, a half dilution. A 1 could read as a 1.5 or could read even as high as a 2. So there's unreliability in that MICs, unfortunately. When you go through the literature and you look at MIC creep, that's been brought up from time to time, regional problems with MICs, you find out that there's very minimal MIC creep in large surveillance studies. In fact, we examined several that had over 29,000 isolates examined. Some the Sentry data had nearly 190,000 or 190,000 isolates that were examined worldwide for susceptibility patterns. And when you look at the most common MIC, it's the MIC90 is 1. Yes, there are 2s out there. We know that there are 2s exist, but I think to a much lower percentage than we were led to believe when we relied on automated systems to tell us what the MIC was. In fact, in our institution, it's not uncommon to have a 0.5. So that really influenced our recommendations on the AUC. So for practical purposes, for empiric dosing, we assume that the MIC is 1 because in most cases, that's the value. And we dose the AUC appropriately based on a 1 ratio of 1. And Catherine, I'm sure you have other comments.
Yeah, we'd love to hear Catherine's opinion on this.
Yeah, so I think, Mike, you very nicely summarized the current challenges we face with accurate determination of MICs and the differences depending on what kind of automated systems that are being used. We recognize that based on CLSI standards, the acceptable variability for MIC measurements is within plus or minus 1 doubling dilution. And so essentially our current testing methods, these automated systems really can't distinguish, between MICs of 1 versus, 0.5 or 1 versus 2. So I think that poses an inherent challenge for the clinician who's trying to decide, well, what do I do with this MIC of 2? Is this really a 2 or is this a 1? And so I think it's important as we think about managing our patients that this really needs to be making decisions based not just on the susceptibility result on the MIC, but also just taking into consideration the patient as a whole, whether or not the patient is having a clinical response. If a patient has an MIC of 2 and this is a catheter-related bloodstream infection with, removal of the nidus, the patient is defervesced clinically and clear their blood cultures, perhaps that MIC of 2 is not one that needs to be acted upon in terms of making dramatic changes in therapy. On the other hand, in somebody has an MIC of 2 but is not responding to standard therapy, perhaps that's a situation where you might want to consider alternative options. So I think it's really important to be considering the clinical context when managing these patients when you're interpreting these MIC results as well.
So target AUC, now that we get into a more careful analysis, between 400 and 600 milligrams per hour per liter is suggested for MRSA invasive infections in adults or pediatrics based on clinical efficacy and safety data according to the recently published guidelines. How, Mike, there may be people listening to the podcast that are not familiar with these numbers. So can you explain how did you get to this number and why this is a good number to be taken into consideration for vancomycin use?
Thanks, Cesar. Actually, the initial recommendation for an AUC of 400, the minimal AUC, was actually recommended in the 2009 guidelines. And the original number starts off in vitro studies and in animal studies, where we're looking for the threshold by which you get at least a 2 log or greater reduction in bacterial load at the infection site. So animal studies, pharmacodynamic animal studies that were done many times over, have shown us that the minimal AUC for total drug concentration is around 400. It gives us a log reduction that we're looking for, again, a minimal of 2. Now, to follow up on that, there were some clinical studies that looked at eradication rates of MRSA from the respiratory tract, looked at data from in bloodstream infection patients with complicated bloodstream infections, and they basically have shown that range, that minimal number is compatible with improved patient outcomes in terms of improved eradication rates of staph from the tissue, from the bloodstream. A lot of it has been clinical retrospective evaluations, but Catherine already mentioned one of the prospective trials, which was the PROVIDE trial that was published in 2019. But there's actually been 3 or 4 prospective studies that have shown improved patient outcomes, that is patient survival, eradication rates improved, and improved safety by ranges of AUCs that are in that pocket, that 400 to 600 range. One might ask, where does it stop? What's the height of that cap at 600? And that really has to do with the nephrotoxicity potential. Like any drug, and especially this particular drug, nephrotoxicity is associated with accumulation. So the longer you're on the drug, the more your tissues, including your renal tissue, are going to accumulate over time. And that's where you start reaching that danger threshold, not that dissimilar to what we see with aminoglycosides. And so what we know now from more recent studies is that getting a value above 600, the 650, 670, up to 700 for adults is the danger zone, where you start to see rapid rise in AKI, secondary to vanco exposure. And for pediatric patients, they're a little more resilient, as you know, in terms of their kidney function and protection, is around 800. So the committee talked about these studies, and we decided to cap it at 600 with the minimal threshold of 400.
So very important consideration. Catherine, we struggle in clinical practice in the past to try to get troughs. And when you start now talking to the clinician about AUCs, there may be some challenges. So what challenges do you see in implementing these guidelines in clinical practice among infectious disease physicians and other kind of critical care and other specialties?
So great question, Cesar. I think the biggest challenges really have to do with shifting behavior and the implementation of a practice that has been in place now for many years. Yes, I think for a long time we struggled to get troughs, but I think this has really now been ingrained into routine clinical care, and most people are quite familiar now with the previously defined target concentrations that were defined in the 2009 guidelines. And so this does represent a significant change for practicing infectious disease physicians, other internal medicine physicians, pharmacists, as well as trainees, where I think we've been essentially this has become part of our routine culture, so to speak, to be monitoring vancomycin troughs. And I think that the 2009 guidelines indicated that measuring peak concentrations were no longer necessary, because that was actually a practice that was in place prior to that, and recommended a shift trough-only monitoring. And now 10 years later, after years of being told that monitoring peak concentrations are not necessary for vancomycin, clinicians will now need to relearn and adapt and order peak and trough concentrations again. But I think that this is a part of the nature of medicine. What was old becomes new again. We adapt as new information becomes available, even when seemingly contrary to what was previously established dogma. And I think we've seen this time and time again with medicine, with things like steroids and sepsis, and in the COVID era, the issue surrounding masks. So I think it will take some time for us to unlearn the trough mindset and shift this paradigm to AUC monitoring. Frontline clinicians will have to rely on values that are calculated by pharmacy rather than looking at a single laboratory value that they can see in the electronic medical record. And this may generate some confusion. I think clinicians may need to learn to ignore some of the lower trough concentrations that they previously considered subtherapeutic, that may in fact be appropriate for patients when using AUC monitoring, and clinicians are going to have to resist that urge to not increase the dose to target a higher trough. So again, this I think will require significant education and behavior change so that people are not reacting to something that we've been so conditioned to react to. I think one particular area of challenge I see is with transitions of care when patients get discharged to OPAT and home infusion, to skilled nursing facilities, especially if the receiving institution has not adopted AUC monitoring, where resources may be more limited to support this type of approach. The other thing I'll just comment on from an operational and logistical standpoint, I think getting levels timed correctly could potentially be a challenge as well, and does require some coordination with nursing. For some patients with MRSA bacteremia with limited venous access, obtaining 2 post-distribution levels might also be a challenge. And then some of our pharmacists here at our own institution, I think, have also expressed concerns about error with hand calculations, and want to get others to double check their calculations before sort of feeling confident that they can move forward. And I think that some of the Bayesian software programs that perhaps Mike can speak to can be helpful in this regard, but these are also costly and may not be supported by all hospitals. And so I do think that implementation of this will take time. It's going to be a multidisciplinary effort that requires pharmacy, nursing, phlebotomy, laboratory services, the frontline clinicians, and really educating people on the why and the rationale for making the shift in practice, and to really develop systems to streamline the logistics of this change.
So following in that point, which as you touched on is very important, in academic and medical center, we have probably, access to good pharmacy teams and labs, but in the majority of the rest of the world, particularly in developing countries, this is going to be very difficult. And, even getting at a trough or a level may be challenging, and you want to get it right. So, Mike, why don't you give us sort of a practical recommendations on how to do this? Will there be an app that people could potentially input sort of values? When do they have to take the sample? Practical things for people to start thinking about how to do this in the right way.
Well, I think Catherine has already mentioned a few items that are important, no matter what the circumstances are, whether you're in a community setting with limited resources, or if you're in a academic hospital with much more resources. I think the most important point, even if it's just a trough level, is the timing, getting the timing along with the concentration from the lab, because obviously garbage in, garbage out. So if you don't have good help from phlebotomy, from nursing care to tell us exactly when those concentrations were drawn, then it doesn't matter actually what calculator you use or what Bayesian program has available to you, because you're not going to get the right answer. So that's the most basic thing that you could possibly do, is to make sure that you have in place a system that ensures that you have some quality checks on when those samples are being drawn.
So when sorry to interrupt, when would be the best time to take a sample in a normal patient with a normal kidney function?
So great question. So vancomycin is a very complicated drug. So we like to simplify it, and that's what most people have done using one compartment kinetics. So assuming that the drug only lives in the central compartment, the bloodstream, which is of course untrue. Most antibiotics, like vancomycin, are multi-compartment. So they live in the tissue and in the central compartment. That would be 2 compartments. And some have deeper penetration, so we have even a 3rd compartment. So vancomycin is one of those animals. It's actually a 2-compartment drug, and we're applying simple pharmacokinetics to a very complicated pharmacokinetic profile. That being said, we've been using 1-compartment modeling for aminoglycosides and for vancomycin, and I think that is relatively safe, and although there's minor errors associated with that. So the best time to take a sample is after the distribution phase of the drug has been completed. In vancomycin, for somebody with normal weight, 70, 80 kilograms, normal renal function, creatinine clearances in the 80 to 100 mils per minute, usually an hour after an hour infusion, at least 45 minutes, but it's easier to tell people to do an hour after an hour infusion, would be a safe area. In other words, you would likely be in the central compartment now, and now you can draw your second sample for AUC dosing, and you can now get a pretty good estimate of what the clearance of that vancomycin is. So that is, how is that patient actually handling that drug versus what your estimates of the patient handling. So an hour after an hour infusion. Now that changes. So if you look at our recommendations in the new guidelines, if you increase the dose to 1,500, for example, from a gram, you may have to increase the infusion time period. So instead of being an hour infusion, you go to 1.5 hours. So most hospitals have in place the infusion time related to the dose for safety reasons, as well as for when samples are going to be drawn. So organizing yourself so that you're drawing samples at the appropriate time, they're far enough spaced apart. If you're trying to get an elimination rate half-life off a drug, you need to have your samples far enough from each other so that you can actually get a pretty good read of what that half-life might be. So typically 4 to 6 hours if you can do it, depending on the dosing interval, whether it's 8 or 12 hours or 24 hours. Now, in terms of limited resources, one of the nice things about the internet is there's a lot of free calculators available right now, AUC calculators that people can download and use. And there's more every day. In fact, I was just made aware of another one that's available to everyone if they certainly are a prescriber of one of these current medical information kits that everybody knows about. But if you are, then you have access to a calculator that will get you to the AUC. If you're in a sophisticated medical center, like the University of Maryland, for example, they've integrated their calculator into the EMR. And so now when they pull the EMR up, it also has the calculator and it integrates the information into the calculator. So that means if the creatinine changes, the calculator has the new information. Not everybody has that, of course. At the Detroit Medical Center, we put a calculator together based on our population PK data that we have or derived from the literature. And that's available on our intraweb. So all pharmacists can just go to the intraweb. They have a calculator available. They put in their desired target. They put in the patient's height and weight, the creatinine, and it will give them an estimated dose and dosing interval. Actually gives them several to choose from. So there are a lot of those calculators available right now. In fact, there's a publication on that was published in the journal Pharmacotherapy in 2019 that lists most of the available programs, including the Bayesian programs that are out there as well, that are there for purchase, or there are actually some free programs if you want to take the time to learn how to use it. So I think getting a calculator is not that difficult. One of the important points about the calculator, you just have to know where the population estimates are coming from. So let's say that I have a trauma patient population, which is what I do at Detroit Receiving Hospital, and I want to use one of these calculators. I would want to make sure that the estimates that are in that calculator, the estimates of elimination rate constant, the estimate of the volume of distribution, sort of fit my patient population. Because if it was derived in a community setting patient population, then I'm going to have an error in my estimates of the AUC until I get actual levels from my patient. Then I can correct for that. But if I find a calculator that has a population PK that are similar to my patient population, then it's more likely going to give me the correct estimate or not far from it. And then when I get new levels from the patient, I can correct from that because now I know how that patient will handle it. So the good news is there's 10, 12, 13, 15 calculators that you can download for free. Some of them are in the app form, and some you have to pay for. And there are commercial available Bayesian programs as well that, again, if you can afford it, you can put it into your system. You can use it as a standalone app, or you can use the free version of it as well.
Okay, very useful tips. Thank you very much. Catherine, the majority of data that we have is in Staph aureus bacteremia, of course, because it's an important disease. But as you know, Staph aureus disease is many protein and different, particularly bone and joint infection, etc. What are your thoughts about applying the same parameters to other infections? Or should people refrain from doing that since we don't have strong data on this?
I think it's a really good question. I think we often struggle with this type of scenario when we just don't have the data to inform us. And as you mentioned, the vast majority of the data to support AUC guided dosing monitoring for vancomycin are for patients with MRSA bacteremia. We don't have information for other invasive MRSA infections, such as meningitis, as you mentioned, bone and joint infections. And many of these infections do present with concurrent bacteremia, but it's really important that we have future research that addresses these other infections and whether the targets that we use for bacteremia are the same. For a patient with meningitis, do we need higher targets, or for bone and joint infections? I think we simply just don't know. There was a recent paper that Mike can, I think, speak better to that was published from his group in CID that looked at AUC targets for complicated MRSA skin and soft tissue infections. I think we need more of these type of studies looking at other invasive MRSA infections to identify what the appropriate targets are. I think it's difficult to know how and if to be extrapolating from these guidelines to these other clinical syndromes. I think we simply don't have the answer to that. And we need more data.
So, Mike, let's talk about these difficult populations: obese patients, for example, patients on renal replacement therapy, and ICU patient where we know the PK/PD parameters change dramatically. So what are, in general, practical recommendations to calculate AUCs on those populations?
Thanks, Cesar. These are challenging patient populations, and the committee did spend quite a bit of time looking at special populations like obesity. Obesity is an issue for us because we are dosing vancomycin in total body weight. And so the problem with obese patients is that we tend to overdose them because their clearance doesn't match their weight. And so we have some recommendations where we've capped certain doses in obese patients so we don't overdose that. And then we have the critical care patients as well, very challenging, changing all the time. My advice, and the same advice I just gave my students the other day, we're talking about vancomycin in these types of patient populations, is that I would give a dose. Whether it's a loading dose or a first dose, give a dose and take your concentrations right away. One of the beauty about using AUC dosing is you don't have to necessarily wait till steady state. You can get an initial read right away. And so estimates are great. And if you use the right patient population estimates, you're probably going to be close to what your target concentrations are. But the best thing you could ever do for a patient, if you're sure you're going to use vancomycin, give the patient a dose of vancomycin. You have the entire dosing interval now, whether it's 8 or 12 hours or 24 hours, to get your concentrations back and actually know exactly how this patient is handling the drug, get an initial read on their volume distribution so you know how much to give the patient as well. So there's no need to worry about all these patient populations because you got the easiest thing in the world, a tool. You can get the best estimate of their renal function from their vancomycin clearance. We talked about this the other day. There was a patient that had, I was a 49-year-old patient, came in with a complicated UTI, ended up with sepsis, and actually had an MRSA infection. patient was treated with vancomycin, their creatinine was only 0.49. And so their creatinine clearance was coming back like about 150 for a 49-year-old patient. Now, there are circumstances where there are augmented renal clearances, and we know about those patients. Typically, they're critical care, but this patient was not that case. And so one of the problems was the creatinine. Was that really reflecting this individual's true renal function? It turns out this patient was immobile and had been in a nursing home, so they didn't have much muscle mass. That's probably one of the reasons why we're not getting an accurate read on the creatinine. And the same recommendation was made to the ID team: just give a dose. Let's figure out what the actual clearance is, and we'll be able to put the patient on in the next dosing interval what the right dosing interval is. And I'm glad we did, because we would have overdosed that patient. The recommendations were to give 1250 every 8 hours, and we ended up giving a patient something like, I think it was every 24 hours for that particular case. So test dose, get the levels, don't wait to steady state. Now you have an accurate read, and adjust as needed.
Catherine, following these thoughts, we tend to use this data, as I mentioned to you, to generalize. How about other gram-positive infections? People tend to think that if it's a Staph aureus, it will work the same in coagulase negative staph, even enterococci. We should tell people about that.
So, I think we discussed this quite at length on the panel, and because I think we actually got some questions about this during the public review comment phase, where people were asking whether we could comment on whether these guidelines could be extrapolated to these other organisms. And we do state very clearly that in the absence of data to guide us on appropriate targets for these other pathogens, that we do need to be very careful about extrapolating these guidelines to some of these other organisms. And I think we saw this practice with the previous guidelines as well, where we saw trough targets of 15 to 20 being used and applied in practice to patients with coagulase negative staph bacteremia, for example. And I'm not aware of any data at this time to support appropriate AUC targets for coagulase negative staph. I'm aware of two small retrospective single center studies evaluating AUC-MIC targets for vancomycin among patients with enterococcal bacteremia. But again, the data is incredibly limited. And so I think that we need to be very cautious about generalizing the recommendations from these guidelines to other organisms. I think it's really important that future studies rigorously evaluate optimal AUC targets for these other pathogens. And I think until then, I would be hesitant to extrapolate from these guidelines.
Very important points. Thank you very much. Mike, a final point. You and many other people have studied combination therapies with vancomycin, and studies are ongoing to evaluate the clinical efficacy. And it is likely that some of these partner drugs may affect the efficacy, may make vancomycin probably could be the scenario in which this combination may be more useful than the monotherapy. In that context, how do you envisage that these dosing intervals and parameters are going to be used?
Yeah, so that's a great question. So as the both of you know, combination therapy is becoming more common. Vancomycin failures have been reported, and clinicians often go to adding on drugs, and there is data that supports the use of Betalactams added to vancomycin for increased efficacy against staph, including MRSA. And in the laboratory, there's no doubt that you can show that there's a lowering of the vancomycin MIC in the presence of the beta-lactam. And for that matter, we can show a lowering of the beta-lactam MIC in the presence of the glycopeptide, the so-called seesaw effect that everybody has spoken about. And adding a beta-lactam has been documented to shorten days of bacteremia. And we know there's some debate out there whether it really influences mortality, but you always have that salvage patient that you want to eradicate that organism, especially from the bloodstream. If you have a bacteremic patient, and adding on one of these drugs seems to be a reasonable approach. The question, though, is does it really change the pharmacodynamics? It does. So it would change the AUC, and it would change the requirement for the dose. The problem is as Catherine pointed out, for many of these areas, we just don't have any studies clinically yet, not even in animals, for looking at the impact of adding a beta-lactam and the change in the AUC requirement to meet that threshold that we talked about earlier today, that whether 400 would be needed anymore, or could you actually half that to 250? And of course, lowering the exposure of vancomycin is going to be more protective. So we don't have that. And then presently at the Detroit Medical Center, we have a pathway in place for MRSA bacteremia. So once that organism has been identified in the bloodstream as MRSA, patients do get not only an ID consult automatically, but they do get a beta-lactam added, in our case, usually cefazolin, to that regimen. And that's an ongoing study, actually, that has been taking place since 2016. However, what we don't do is change the recommendation for the AUC right now. So we apply the same rule, 400 to 600 for vancomycin, and whether the beta-lactam is there or not. The good news I can tell you is from the Detroit Medical Center, we started AUC dosing in 2015, and we actually studied and published actually in antimicrobial agents of chemotherapy, since we're talking about the journal, just a year or two ago, from our experience of monitoring troughs versus monitoring AUC, and we showed a definite decrease, a significant decrease in nephrotoxicity across all of our 8 hospitals. And that sustained suppression of nephrotoxicity by switching to AUC dosing has been maintained for the last 5 years. We look at it monthly, and it's reported through the stewardship committee, through our quality assurance group, and it's working. And Catherine's already mentioned this. And the reason for that is that the dose is lower. We use less dosing by doing AUC dosing. You use more drug when you do trough monitoring of 15 to 20, and you use less drug when you use AUC monitoring. And that is the explanation for the safety.
Catherine, any final thoughts on combination therapy?
You know, I think I actually sort of have a question, actually. Just we've been, there's been, you know, emerging data, as I think both of you know, over the last couple of years regarding the combination of vancomycin and piperacillin tazobactam and the association with nephrotoxicity, and then sort of wondering, you know, how much of that, you know, and I don't think we saw that data really emerge until kind of in the more recent years following the 2009 guidelines, and I'm wondering whether or not that association may still potentially be present in the era as we shift more towards AUC monitoring, whether or not that is something that we would continue to see. And it's really kind of more of a question, I think, interested in Mike's take on that.
Yeah, actually, that's a great question. We have a study that's undergoing right now, evaluating multi-center, evaluating AUC dosing for that interaction between piperacillin tazobactam and vancomycin to see actually, is it lowered? We know that piperacillin tazobactam, at least we feel, has a higher rate of toxicity in combination of vanco compared to cefazolin or compared to cefepime, for example, because that's another empiric choice people use when they don't exactly know what they're treating and they want to be broad spectrum. So they add vanco to cefepime or add vanco to pip-tazo. But your question is unknown. And we feel, based on the data from vanco alone, AUCs, that it should impact that combination. We should see a lowering, but that we haven't answered that question yet, and it's ongoing. So it's a great question. Hopefully we'll have the answer soon.
So a lot of research to come forward. Thank you, Catherine. Thank you, Mike, for the fantastic points and guidelines on the new published vancomycin use guidance. This is Cesar Arias, AAC Editor-in-Chief, signing off. Thank you very much.